Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Vive Healthcare.
This program is presented by Medscape Education Global.
Hello, I'm Chloe Orkin, Professor of Infection and Inequities at Barts Health NHS Trust and Queen Mary University of London in the UK. A warm welcome to this program entitled The Physical Implications of Stigma in People Living with HIV. Joining me today is Dr. Miley Young-Karras, and she is Associate Professor of Medicine at the University of California, San Diego. Welcome, Miley.
Thank you. It's a pleasure to be here.
It's a pleasure to have you. Today, we're going to discuss the types of stigma experienced by people living with HIV and the impact of the stigma. We're going to talk about the link between stigma and stress and its clinical implications, the effects of stigma and stress and the stress that it causes at a cellular level, and finally, interventions to tackle the stigma. So, Miley, could you start us off, please, by introducing the concept of stigma, how it impacts people living with HIV, and why this matters, please?
Thanks, Chloe. So to start us off, I think it's always helpful to define what we're going to be talking about. So HIV stigma encompasses the negative beliefs and attitudes that our societies associate with HIV, and it can manifest in several different ways. People living with HIV may internalize their HIV stigma, viewing themselves in a negative light because of their diagnosis and because that's what our culture communicates to them. On the other hand, people living with HIV also experience HIV stigma when assumptions are made about them and or they are treated differently when their status is disclosed. For example, I referred one of my patients with chronic pain, also living with HIV, to water physical therapy, and his insurance denied it, specifically stating HIV as a contraindication for him to be able to use a pool with other people. Clearly, external or enacted stigma is sometimes called discrimination. In the middle is perceived or anticipated stigma, where a person with HIV perceives that they are or will be treated differently because of their HIV. And this is influenced by both their internalized stigma, or their feelings about themselves, and their experiences with discrimination. HIV stigma is often just the tip of the iceberg for people living with HIV. Commonly, there are other society stigmas that intersect with HIV, such as racism, misogyny, sexuality, substance use, ageism, just to name a few. And regular exposures to the experiences of stigma related to these different identities impact not only their life experiences, but they impact our life experiences too. And this can happen across multiple levels at the individual level. So you might feel uncomfortable because someone has said something that's racist or other to you. It also affects our relationships, our interpersonal level, and it affects us at a societal or a structural level. Overall, these lifelong experiences of intersectionality and our own struggle with them additively negatively affect our health outcomes. So the reason that we really wanted to talk about HIV stigma today is because it matters. It impacts societal practices and the experiences of our patients. It contributes to ongoing health disparities as well as health outcomes. And it can lead to concealment, social exclusion, and isolation, all of which impair our worldwide goal of eventually ending the HIV epidemic. So, Chloe, how common is the experience of HIV stigma, and what are the clinical implications?
Everything that you say hugely resonates with me, and I think that Kimberly Crenshaw's work on intersectionality and defining intersectionality is some of the most powerful and helpful constructs that has ever helped me to put into context what I see in clinical practice and also my own experiences. So I just wanted to amplify the points you're making and just say how powerful I find them. But I think that sort of moving to a more sort of HIV clinical perspective and sort of trying to connect people's experiences and stigma in terms of what they tell us. I think a piece of helpful information is the recent findings from the Positive Voices survey. And this is a survey that's been done in people living with HIV for several years. It was done in 2017 and it was done again in 2022. And what I find really, really striking about it is that people are still finding, so more around 70% of people still find it difficult to tell people about the fact that they're living with HIV. And shame is a huge factor. So people saying that they're ashamed of their status. This is a fact across the board, because I think we often tell ourselves that minoritized communities are experiencing shame, but actually this is not something that people now experience in the U equals U era. It's okay to live with HIV. This is all fine internally, but actually this is shown that across the board people are experiencing this, men and women. Gay and bisexual people, heterosexual people, this is a big issue. And people also talking about self-esteem and how it's affected their self-esteem in 2022. And I think also people are reporting stigma in multiple different settings. And they're reporting events of stigma in the last year and also more than a year ago around different public spaces, in relation to the police, in relation to healthcare settings, healthcare staff. And a lot of this stuff is really important in terms of potential for avoidance. People also have described this in relation to their friends, their social circles, and discriminatory remarks from family and exclusion from family activities. So I think that that's, very salutary and really it is shocking to read it. Although you know it when you're in clinical practice, it is shocking to see it collated into bar charts. And I think also there was a specific focus in the survey around the stigma that people experience in healthcare settings. And, they particularly quantified feeling afraid of going to healthcare services because someone might learn the status. And they found this in more than 10% of people felt this. And hearing people gossiping about them, being worried that they're treated differently to other patients, that came up very highly in almost 15% of people. And avoidance, in a large proportion of people. So I think, this is a real wake-up call, because this is not a survey that's been conducted, in a country where HIV is criminalized or people who are gay are criminalized. This is the UK. And while I know we have our problems, this is, very striking. So I think the other things that I would say about this is, in terms of the consequences, taking some sort of a snapshot of all of this, I would say that, stigma consequences are things like leading to concealment, non-disclosure of status, a lower quality of life. That's really clear from the things that I've been talking about. High rates of depression are also something that has been described, and stress is something that really has come through, self-esteem, as I pointed out, and overall poorer psychological and physical functioning, which is not hard to envisage if you think about people that are feeling estranged from their families, gossiped about by friends, and decreased ability to complete daily activities. Avoidance is really writ large here. And obviously, if you're experiencing all of this, you are likely to have low levels of social support. And also, this can affect adherence, because you need to engage with your services in order to adhere to treatment. You need to attend, to have your blood tests, to see a doctor or a nurse, to get your tablets. And you can see that this would also affect how people use health services, which again would affect not only treatment, but potentially prevention, in terms of people being willing to access care, to do an HIV test, or to access PrEP. So I know that I've talked a lot, but what I would also like to raise is the fact that some of these issues, are, I think we are growing in our understanding in the fact that mind-body dualism is actually not a very helpful paradigm. What do I mean by that? We often have thought of things that are sort of social constructs like loneliness as, something that people experience, but not really entirely connected it to health outcomes. But in recent years, there's been a lot of research, and it has shown that things like loneliness and social isolation can lead to a 25% increase in risk of early death, up to 30% increase in risk of stroke and cardiovascular disease. And it's similar in terms of as a risk factor to smoking for 15 years. I mean, that is really, in fact, it's more so than that. It's really shocking. And also that loneliness can increase the risk of developing dementia by up to 50%. And this is based on a World Health Organization report. So I think it's important for us to maintain a perspective, a macro perspective, not only in terms of our own patients in our field in terms of HIV, but understanding that for everyone in the world, this is the case. And these things are, very, very significant, serious stressors. And I think that, these HIV stigma can lead to loneliness, as I've explained, because people feel isolated. But there are also forms of stress that people experience, such as depression, anxiety, PTSD, reductions in self-efficacy, and that means someone's ability to try and act for themselves, to take the actions, self-care actions that are needed in order to achieve good health outcomes, and obviously social isolation. People may turn to substances in order to cope with this. And also these factors in turn, these forms of stress, lead to adverse health outcomes on things like treatment adherence, which is the very obvious one in terms of avoiding healthcare, things that affect quality of life more generally. And then, of course, as I have mentioned, substance use. And I think that it's important to recognize that these events can lead to non-AIDS associated comorbidities that can increase the likelihood of cardiovascular events and various other events from happening. So having said all of that, with the understanding of the prevalence and clinical impact of stigma in people living with HIV, we'd like to move on to try and understand more about the underlying mechanisms that drive outcomes. And I'm relieved that it's you and not me, Miley, that is going to have to explain our current understanding of the effects of stigma-induced acute and chronic stress at a cellular level. So on that note, I will hand over to you.
Thanks, Chloe. I'm glad that you brought up a little earlier about, this idea of it's not just the mind and it's not just the body, but all of these things are working together. And hopefully in these next few slides, I'll be able to convince folks that indeed is true and that we actually have quite a bit of robust science to demonstrate that. I think we first began to believe that there was more to this mind-body interaction when we started to look at observational studies. So we already know, from looking at observational studies that stress has very far-reaching outcomes, and stress being the manifestation of HIV stigma, the manifestation of all the other types of intersectionality that we've brought up, as well as associated consequences like poverty, substance use, etc. We know that people who are chronically stressed, for example, psychiatrically ill persons, like persons who have schizophrenia, are at increased risk of accumulating comorbidities and often demonstrate a reduced life expectancy. We also know from the Women's Interagency HIV study of about 700 women that women living with HIV that demonstrated or reported having a high psychosocial risk, which they defined as depression, high levels of stress, and or PTSD, demonstrated carotid artery focal plaque prevalence of 23% versus 11% in women that did not report those same type of psychosocial stressors. In this study as well, so that was just a snapshot, but looking longitudinally, they also identified that women that had very high depressive symptoms, usually about 45% or more of the visits, was also associated with some new plaque formation that occurred. So 17% compared to 9%. So there's something about these psychosocial risks that is increasing comorbidities. We also have a better understanding of the mechanism between stress and health outcomes, such as cardiovascular disease and cancer, like we've been talking about. Other conditions that have been associated with systemic or chronic stress is diabetes and kidney and liver disease. And essentially, stress and isolation, along with chronic infections like HIV and CMV, our diet, inactivity, etc., and whatnot, contribute to a chronic state of systemic inflammation. So it is this systemic inflammation that all of these different things cause that is contributing to the future risk of some of these consequences. In fact, the association of stress and inflammation is so well established that in the Interheat study, which is a large study that evaluated the potential effect of modifiable risk factors with myocardial infarction across 52 countries. So this is not just a US-based study or a UK-based study. Chronic stress was considered the third most important modifiable factor behind lipids and tobacco. Think about that. So there's actually also quite a bit of robustness in the literature behind this. What stress does is it activates the hypothalamic pituitary adrenal axis, or the HPA axis, if you can all remember back from when we were in medical school, if you haven't done this in a while. And that is a main producer of cortisol. And this results in higher levels of circulating cortisol concentration overall, as well as subsequently impaired glucocorticoid receptor sensitivity. So you've got lots of high cortisol running around. The glucocorticoid receptors become less sensitive to that. And over time, if you have this chronically, then it can lead to this state of chronic overaction of the HPA axis. And multiple downstream effects occur from that. So downstream effects such as vasoconstriction, decreased nitric oxide production in endothelial cells, and nitric oxide is actually very protective against atherosclerosis, and enhanced oxidative stress. So what we see is that it manifests as hypertension and increased atherosclerotic risk. So stress also may impact the balance between our sympathetic and parasympathetic nervous systems, and evidence suggests impaired parasympathetic activity, meaning that the body is constantly in this state of fight versus flight. We also know that stress in the social environment that one exists in can alter genes. So I love this table about the conserved transcription response to adversity, or CTRA, because it kind of really describes the whole process that this occurs in. So first, someone exists in an adverse environment. And again, that could be HIV stigma, that could be traumatic events, it can be poverty. So a whole bunch of different contexts has been demonstrated already to impact the CTRA gene block. When someone is in that context, they begin to feel very threatened by their environment, and they have this perception, which then activates the peripheral nervous system, this sympathetic nervous system that we were just talking about. And from there are multiple pathways that ultimately lead to changes in the gene regulation of this block of genes called the CTRA, or conserved transcription response to adversity. And essentially what this block of genes does is it contributes to a dysregulation of the immune system. So essentially what happens is it causes a general sense of chronic inflammation, but it also decreases the regulation of genes that are involved in innate antiviral response. So it also causes a little bit of immunosuppression. It's a combination. And it's this dysregulation of the immune system along with this chronic inflammation that has been associated with suppression of other things. So I think another thing that we've identified is that stress in this way may also impact aging. So one of the downstream effects of CTRA, and again, this chronic inflammation and immunosuppression at the same time, is that it looks like it impacts our telomeres. And for those of you that may not be familiar, telomere length is associated with aging. What stress does to telomeres is it tends to suppress the basal telomerase activity, so it cannot add more telomere length, and it also is associated with decreased telomere length. And currently, it's believed to be secondary to this proliferation and persistence of what we call these senescent immune cells, or these older T cells that are just circulating in the body and not getting eliminated. We don't quite know yet what the consequences are of these observed telomerase changes with stress, but it is certainly something to keep an eye on in the future. And I think probably more relatable to most of us, I think many of us have already experienced the impact of stress on the gut in some capacity. I mean, I'm an introvert, believe it or not. And it's been over a decade, but I very much remember how my gut used to feel when, as a first year in my infectious disease fellowship, I had to present case conference in a room full of experts. That's just one example of how stress impacts the gut. But chronic stress can do so much more than that. Changes such as mast cell degranulation can result in mucus thinning and increased gut permeability, which then contributes to gut translocation. So bacteria and other microbes and microparts can kind of translocate into the blood, and subsequent systemic inflammation. So in summary, chronic stress leads to multiple changes along multiple pathways down to the level of the genes that results in a mixed picture of chronic inflammation and immunosuppression. When it's paired with HIV, so if some of you are maybe already be knowing where I'm going with this, but HIV also results in a mixed picture of chronic inflammation and immunosuppression. So people who are living in a state of chronic stress and HIV are really experiencing a double whammy.
Absolutely. And I think the other thing that I just wanted to say, just reflecting on everything that you've been saying, is I think that science and the whole scientific process and immunology is often beyond what most people can comprehend. I mean, even, I have to say your explanation was magnificent, and I almost understood it. But I think that in the public domain now, there are books being written about concepts such as weathering, which is why people who, about racism, and the effects of racism, their Lancet series about the effects of racism on health. And this is becoming stuff that people at home can sort of understand. People are hearing that loneliness is dangerous for health. And I think that this is actually potentially very powerful in terms of combating all of these sort of structural oppression that exists in the world, that an average person at home would start to hear about these concepts. So that takes us to the point of interventions, because we shouldn't expect people at home to resolve these problems, and we all have a responsibility. So I think what can be done. Well, I think the first thing is stigma is internally felt. And I think that some of the interventions can be to help people with self-acceptance, empowerment, motivation, behavioral change. It's very important, though, that we don't absolve society of responsibility for change by making people feel that they need to become resilient. And if they experience stigma, it's somehow because of some deficit in themselves. They haven't done enough self-improvement. That's a very important line we need not to cross. It's also important in terms of individuals and relational to convey information, to help people, to share knowledge, to try and help educate people. Once again, it's important to recognize that the onus on educating people should not fall necessarily on not necessarily, it shouldn't fall on the minoritized group. It's not for minoritized people to have to explain and teach other people about how not to be racist. It's also important at an individual and structural level that we all introspect, we all think about what we're doing to contribute to structural oppression and structural barriers. And that means activism. So how do we combat stigma? Well, as I've said to you, and as Dr. Karras has beautifully explained, the multiple layers, the internalized stigma. So, for example, ways to reduce fear of dying would be increasing optimism. And there's a whole literature on optimism versus learned helplessness in the field of positive psychology. There's issues around restored social value and role fulfillment, around productivity. And there are things that can really help with this, such as access to treatment and efficacy with community-wide coverage that can help people to feel that they are, potentially no longer infectious to others. That sort of can really help internalize stigma. U equals U has been very, very powerful. Internally, but things like that can also help in terms of what people perceive and anticipate from others. So if people think that society knows that actually they aren't, that people living with HIV are not going to pass HIV on, you can reduce the sense of anticipated stigma when people are sure that other people know this information. So those are some examples, and I think that that's an example of how the U equals U message is so powerful, both at an individual level and also in terms of experiences of other people. And then in terms of helping people, in terms of enacted stigma, this is where, things that are sort of understanding that there's certain things that are stigmatizing and addressing those things such as, anti-discrimination laws, like macro level pictures, how the media deals with people living with HIV, why it's so important when there are unfair and stigmatizing portrayals in the media of people living with HIV, saying, infectious person, whatever. We have to challenge these narratives, because these are the sort of the macro factors that can affect, perpetuate stigma. So there are things we can do on the positive side. I've talked about, the negative things, but I'm also on the positive side. What can we do? So reducing stigma can be mediated by providing good social support and sort of giving positive messages in a safe space. The longer that people, as people move away from the time of their diagnosis, people have the benefit of time to process things and for things to fall into place, and also to develop mastery, self-efficacy, and empowerment. And this often happens through communities and being in community with other people living with HIV, which is why peer navigation, peer mentoring is so incredibly helpful and supportive. Many people seek support and receive support and strength through spirituality. And then it's also important to recognize that Western medicine is not the be-all and end-all of life. And there are many indigenous cultures, healing cultures, that also have very important things to contribute. So I think that there are not that many studies that directly target internalized stigma reduction and the effects of it. But we do know that U=U has been incredibly powerful. And I think that that is a proxy in some ways for actually developing stigma reduction. So there are also more systematic things that can be done at a clinic level. And there's been some amazing work done on developing a trauma-informed care. And this is really about understanding how to accept that people experience trauma and create a safe space where there is an ability to feel trust and to be open and to receive openness, a place where peer support is available and integrated into the care model, and that the lived experience of the person who's experiencing the illness, because this is bigger than just HIV, is received in a way that it's a positive collaboration and there's some sense of mutuality. The doctor isn't the all-knowing person, the source of all power and knowledge. And then this is around understanding how to amplify people's voices and give them choices and enact shared decision-making and taking into account the effects of cultural, historical, and gender issues, because, the way in which racism has affected, research has left a very deep scar on people in terms of what they expect and how they interface with research, Black people particularly. So I guess that sort of leads to the obvious question of what can healthcare providers do? And I spend a lot of my time asking myself the question, how can I help? And I think, in everything that I do, in terms of the care that I provide, the advocacy that I do, the work that I do with other healthcare providers in the workforce, there's always a question. You can always ask yourself, what can you do to help? And I think, firstly, it's noticed when people are experiencing the effects of stigma. There is a role for understanding that things are not right in the world, and that's pretty obvious. And when you see something that is not right, you should call it out, and you shouldn't let things pass. And you should be the change you want to see, and understand that all institutions need to implement trauma-informed, healing-centered care. And I think it's important to talk about what goes well, what goes badly, and really to drive the agenda on stigma and why we need more research to study its effect in health in general and in HIV in particular. So I think those are some things that I wanted to say, but I'd like to turn this over to Miley to hear your perspective on this.
No, I completely agree. For me, advocacy is huge. I think it's beyond just helping to improve the system for our patients. Like we need advocacy and we need change for us. If we want to continue to be able to do the healthcare that we believe in, which is truly whole person care, like taking care of every aspect of a person's life. And certainly in HIV, I personally think we're very lucky as HIV providers because we do get to do that. Our patients are very open with us. They talk to us about everything. They, they question anything that any other provider says. And I think, it's really a beautiful relationship. And I know that In the U.S., Chloe, I think this is probably very different in the U.K., but we have a little bit of a crisis of we don't know if we're going to be able to have enough infectious disease doctors because there's less and less people going into the field. But really, our job is so fulfilling, and I do think in order to be able to continue the work that we do, we as physicians really do need to be advocates, and we need to be more politically active. We need to take a stand. We need to communicate that like the way that healthcare is not how it should be moving forward, and we need to make a change here. So
yeah,
I don't know if you have other comments, but
no. I mean, I just want to amplify what you said, and I think there are people going into public health, and I think it's about sort of explaining that this is public health and finding ways of explaining that the dynamic between doctor and patient in this field is unparalleled, and we do get to really experience the whole person and to learn from people's lived experience. So if you're a trainee in the audience, or you're considering becoming a trainee in the audience, do it. Definitely do it. So now that you've heard Dr. Karras and I singing the praises of our specialty and of our patients, I'm going to conclude by just really summarizing what I think we've covered. I think that, the bare bones of what we've covered is the whole concept of intersectionality and how that can translate into, 3 layers of stigma, both internalized, sort of inter-individual, and sort of macro structural stigma and discrimination, in fact. And then we've looked at the sort of the biological aspects of stress and how stress can lead to inflammation, and how inflammation can lead to disease. And we've talked about the mind-body dualism and how unhelpful it is, and how things like loneliness can seriously impact on health. So it's not really the mind and the body, we're just all one thing. And then finally, we've talked about our responsibility, because we always have a responsibility and we always have choices, and there are always things that we can try and do to help. And we've given you some inkling of what some of those things could be. So I hope that you have found this helpful. Miley, I found you inspiring, and I found this to be a great discussion. Thank you, the audience, for participating in the activity, and please do continue to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.